Hi, this is Nurse Inga. Today we're going to be discussing paramedic neurological emergencies as part of our summer pediatric lecture series. We'll start off by discussing the concept of altered mental status and some of the causes. A change in mental status occurs when there's a lack of oxygen, glucose, or perfusion to the brain. If the patient isn't in what we would consider a shock state, consider that there's too much or too little of something that they need, such as their temperature is too high or too low, their glucose is too high or too low. They are either in an acidotic or an alkaline state, so they have an acid-base imbalance. They have some sort of an infection that is causing inflammation, especially like sepsis or meningitis or encephalitis. The side effects of drugs or medications can cause altered mental status, or they could have sustained an injury to their head or a cardiac arrhythmia. Common problems that we see as far as altered mental status in pediatrics include things like a drop in their SpO2 below 90, a rise in their CO2 above 45, low blood pressure, so if their MAP is so low that it can't perfuse their brain, a temperature of even a slight temperature. So for every 1 degree that we increase our core temperature, it increases the oxygen consumption needs by the tissues by 10%. So even low-grade fevers can make kids lethargic. Drugs like sedatives, anti-epileptics, are opiates, alcohol, seizures, especially when they're in that postictal state, and increased intracranial pressure from bleeding, fluid accumulation, infection, or trauma. There's different mnemonics that you can use to help think about why someone would have an altered mental status. AEIOU tips is pretty comprehensive, but sometimes, especially 2 o'clock in the morning, you know me and my 2 o'clock in the morning rules. Sometimes it's hard to remember all of those. So that stands for acidosis and alcohol, epilepsy, infection, overdose, uremia, trauma, tumor, insulin, psychosis, and stroke. The mnemonic SNOT could also be used, depending on which one you're in the mood for, and this includes stroke, seizure, and sugar, narcotics, oxygen, trauma, toxins, and telemetry, so obtain an EKG. I want to point out that it's really critical that glucose checks get done on children with altered mental status. Even a small amount of alcohol ingestion can impair the ability of the liver to break down glycogen stores, and so children who have even a small amount of alcohol on board can end up being hypoglycemic. All right, so we're going to move on to seizures first. So seizures are the most commonly observed neurological dysfunction in a child. The etiology varies, so it could be a febrile seizure related to a sudden change in temperature. It could be a epileptic seizure, or they could have partial or absent seizures. By definition, a seizure is any sudden intermittent episode of altered mental status that lasts between seconds and minutes and may include involuntary tonic and clonic movements. There are a lot of causes of seizures. So intracranial inside the head includes epilepsy, some sort of congenital anomaly, birth injuries, infection, trauma, degenerative diseases, and vascular disorders. Extracranial, so outside of the head, includes things like fever, and again, it's not the degree of fever, but how rapidly the temperature is increasing or decreasing that causes the seizure. Heart disease, metabolic disorders, hypocalcemia, hypoglycemia, dehydration, and malnutrition. Toxins include things like anesthetics, drugs, and poisons that can induce seizures. And there are a lot of common kind of triggering factors for seizures, and those include flashing of dark light patterns, so like strobe lights, startling movements, overhydration, and photosensitivity. So typically when we get called, it's for a generalized or tonic-clonic seizure, which we would refer to as a grand mal seizure. These have three distinct phases. The aura, or that kind of pre-seizure sensation, it could be visual disturbances, they might taste something, they might smell something, or they might hear something. And then they have the seizure phase, which is considered the ictal phase, and then the post-ictal phase is after the seizure. And during that time, the person usually has a depressed mental status and is working on regaining their strength and coming to. Partial seizures account for about 40% of all pediatric seizures, and they may have normal consciousness or slightly impaired consciousness. They may have, staring off into space like absence seizures. And they can have simple or complex seizures. So they may have just like a small tic, or they may have, again, a slightly impaired mental status with larger areas of the body that are involved. So things like lip smacking, eye rolling, tongue thrusting, twitching of a single extremity, things like that can account for partial seizures. If we arrive on scene and the person is still seizing, or if they have had back-to-back seizures with no lucid interval, we would consider that to be status epilepticus. We know that people on scene are not great historians as far as time goes. Often, we'll get there within a couple minutes and it feels like hours to them while they're waiting. So a good rule of thumb is if the person's still seizing, or if they haven't had a lucid interval and they seize again, treat the patient as if they have status. Drugs of choice are obviously benzodiazepines to break seizures, and IM is the preferred route because it's safe and it's fast. If you can't do IM for whatever reason, intranasal is also an option. And then, starting an IV and administering an IV push med would be lowest on the list, because if the person's actively seizing, restraining an extremity to start an IV can do musculoskeletal trauma or damage. Be sure when you break the seizure that you check the eyes afterwards. So sometimes the body stops seizing, but the brain is still seizing. And so if you see any, repetitive twitching or shaking of the eyes, the brain is still seizing and the patient needs more medication. As always, benzodiazepines are central nervous system depressants, and so they're going to cause a decrease in mental status, so that postictal phase may seem longer. They decrease respiratory rate, depth, and effort, and so the patient may need ventilatory support, so make sure you're monitoring O2 sat and end-tidal CO2. And they decrease the ability of the patient to protect their own airway. So especially with kids that have those big floppy tongues, we worry about airway positioning. So make sure that you're keeping a careful eye on their respiratory status. Meningitis is an infection or inflammation of the meninges, and that's that thin sac that covers the brain and spinal cord and kind of keeps the CSF in place. The meninges act as kind of a barrier between the inside and outside world and help prevent bacteria or virus or pathogens from getting into the central nervous system. When they get infected or inflamed, then it causes severe neck pain and headaches. It can be caused by viral or bacterial infections. Viral meningitis is usually caused by an enterovirus, like a GI bug, usually in the summertime, and so the person will have a episode of gastroenteritis preceding the onset. Bacterial meningitis is caused by bacteria like Staph pneumoniae or Neisseria meningitidis, and this can progress to sepsis and even death. Newborns can also develop meningitis from bacteria like group B strep that was encountered in the vagina, so the birth canal, during delivery. Fever, headache, petechial rash, so those teeny tiny little blood blisters that become purpuric, which you see here. So when the petechiae sort of group together, when there's so many of them, they create a confluent purpuric rash. So we end up with this purple kind of discoloration. This is not from trauma, this is from internal hemorrhage. Nuchal rigidity, so that's a stiff neck. Photophobia, so exposure to lights and sounds also are common complaints for the person who has meningitis. PPE is really essential because bacterial meningitis is spread via droplets, so you'll need mask, gloves, gown, eye protection, and a surgical mask when caring for these patients. And if something happens and you make it to the hospital without PPE on, hopefully they'll contact your infection control officer and get you on antibiotics. So next we're going to talk about neural tube defects, and I've included some fairly graphic pictures in here, so if you're watching with somebody who's not in your class, they may want to not watch this part. Neural tube defects are most often caused from failure of the neural tube to close at either the cranial or the caudal, so like the sacral end of the spinal cord. The first and probably most devastating is the condition called anencephaly, where there is a severely underdeveloped brain. This is a rare birth defect, and as you can see here, there's a lack basically of the forebrain, and then part of the midbrain, the cerebrum, which is the thinking part of the brain. Unfortunately, the brain stem is intact, so reflexes are intact. The pregnant person oftentimes can feel the baby move, or moves normally during the pregnancy. This is usually caught with prenatal ultrasounds, so during prenatal care, but there are plenty of people who do not wish to have prenatal care, and then this is the potential side effect. So this next picture is fairly graphic. This is a picture of a baby born with anencephaly, so they're missing that forebrain. And you'll notice that the face is fairly normal, but because of the way the skull is modified, the eyes oftentimes look like they're protruding or bulging just because there's no forehead and the top of the cranium is malformed. These children can live, minutes to hours to days after birth. Because again, the brain stem is regulating the heart and the breathing, but they don't have any thought. So while they may have reflexes and movement and may respond to touch, it's simply reflexes and not cognition. Microcephaly is the next neurotube defect that we see, and this is where the person has an intact brain, but it's abnormally small. And you can see here on the left, there's a picture of a normal brain, and then on the right is microcephaly. This is a famous actor who had microcephaly, but you can see that, again, there's fairly prominent facial features, but the forehead itself and the skull itself are very small. And this can impact language, it can impact mood, and it can impact just overall knowledge. Hydrocephalus is when there's an increase in cerebral spinal fluid within the ventricles of the brain, and this causes pressure changes within the brain itself. It causes an increase in head size in patients who have cranial sutures that have not yet fused. So our infants and children young children, and then it results from an imbalance between production and absorption of CSF or improper formation of the ventricles. It's most commonly acquired by an obstruction of CSF outflow from the ventricles of the brain. It can be a sequelae of infection, so it can occur as a side effect of an infection of the brain. And also we can see this in children who had perinatal hemorrhage, so head trauma during birth. Symptoms depend on the site of obstruction and the age at which it develops. So again, if you get this older in life and your cranial sutures have fused, you're not going to have kind of that classic larger head size. There's different types of hydrocephalus. The first is what's called non-communicating, and this is where we have an obstruction of CSF flow from the ventricles to the subarachnoid space. So we're making CSF either normally or excessively, but it's not able to be transferred to the spaces where it would be reabsorbed. Communicating hydrocephalus is where CSF is not obstructed in the ventricles, but it's inadequately reabsorbed in the subarachnoid space. So for non-communicating, there's an obstruction, it gets stuck, and for communicating, it can still move, but it doesn't get reabsorbed. And then there's a condition called normal pressure hydrocephalus, and this is where the person has an increase in CSF in the brain, but they don't have an increase in intracranial pressure. So this is not usually seen in children. This is usually seen in adults after things like a head injury or a stroke. This is a picture of an infant with hydrocephalus. The manifestations of the condition will depend on the severity of the imbalance, so how much fluid is in there, and the time of onset. So again, the younger you are, the more molding and changing of the head size you might see. The classic signs then are an increase in head size in children. Cranial sutures separate to accommodate that enlarging mass, and so you may feel like a bulging of the fontanelle in a small child, and you may be able to feel gaps between the sutures. Super, super important. This head is so heavy. So a normal kid's head, we joke about them being like bowling balls. They're so heavy and they always like fall head first. But a child with hydrocephalus has so much extra fluid that they can't support the weight of their head. They oftentimes can't even turn their head from side to side if they have significant hydrocephalus. So when you're picking this kid up, do not pick them up underneath the armpits. Their head will just snap back. So it's really important that you support the head and very carefully, because if those sutures are open, you could, do damage if you poke at it. So really gentle repositioning and supporting that big heavy head is critical. Because of the stretch and the increased fluid, you'll see a really shiny scalp and dilated veins, and then a high-pitched cry, which indicates increased intracranial pressure and discomfort, pain. And then this hallmark sign here is called these sunset eyes, and this has to do with pressure on the nerves that control eye movement. You can see in this picture that this child has actually had a shunt placed. You can see a suture line at the top where there's sutures still in place, so it's fresh and it's healing. And as the hydrocephalus resolves after the surgery, the eyes will resolve and the head size will resolve as well. So shunts can be ventriculoperitoneal, some from the ventricle in the brain into the peritoneum, or they can be, and that's called a VP shunt, or we can do what's called a VT shunt, which goes from the ventricle into the thorax. Basically, this is a tube that runs from the ventricle in the brain down the side of the neck and head behind one ear, and it's tunneled, so you can feel it behind the ear and a little bit in the neck, but then it's underneath everything in the chest. So unless the child is very, very thin, oftentimes you can't feel the shunt itself. this tubing in the chest wall. So in this picture, it just ends up in the peritoneum, and the cerebral spinal fluid then drains in there and it's reabsorbed and it decompresses. You'll notice that there's an area behind the ear labeled pump, and this is a little area that's kind of spongy that you can depress, and not you specifically, but the caregivers are taught to pump the shunt to prevent it from getting like clotted off or obstructed. Signs of shunt malfunction, which would be an obstruction and increase in CSF, are things like headache, lethargy, and altered mental status in the older child, and then the high-pitched cry, bulging fontanelles, and sunset eyes in the younger child. If you suspect that you have an obstructed shunt, that is a surgical emergency, and you should consider aeromedical transport if you are not close by ground to the facility where that child usually receives their PD neurosurgery care. So with the neural tube defects, spina bifida is going to be the last one that we're going to talk about. We know that these are, in theory, mostly preventable. People prior to pregnancy should take 0.4 milligrams of folic acid or more. So that's like 400 micrograms. And people usually either take 400 micrograms, 800 micrograms, or like a whole gram of folic acid every day prior to becoming pregnant. And ideally throughout the entire pregnancy, but it's really critical that at least the first 12 weeks during the pregnancy that the person is taking a prenatal vitamin with folic acid, or at least a folic acid supplement. And I want you to remember that like the day that fertilization occurs, the person is technically like 2 weeks pregnant, because that's usually about 14 days. Ovulation occurs about 14 days from the onset of the last menstrual cycle, so when they had their period. So that's 2 out of those 12 weeks. And then the person usually won't know for at least another 2 weeks that they're pregnant. So that first 4 weeks, which is when all those organs are forming, that's like the really critical time to have all of the correct nutrients and building blocks on board. So that's one of the reasons why we really want people to take supplementation prior to becoming pregnant and then throughout the pregnancy as well. So when you are thinking about, I'm going to birth this baby in the field, and what are my risk factors and potentials for needing resuscitation, the lack of prenatal care increases the risk of neural tube defects. So if the person hasn't been taking prenatal vitamins or folic acid supplementation, if they didn't know they were pregnant, if they lacked prenatal care, that definitely is a big red flag for us that this child might need resuscitation or might have some sort of congenital defect. So there's 3 types of spina bifida. The most benign or least severe is called spina bifida occulta, which is basically an occult finding. So it's the opening in the back is usually very small, or it's just like a dimple, like a sacral dimple, we'll call it, or they might have a tuft of hair or a lipoma, or even just a discoloration at the site. So you see here this patient or person has a tuft of hair in the sacral area. There's no protrusion of structures, and this is, again, considered very minor. Treatment is generally not necessary unless the person has gait disturbances as they get older or problems with bowel or bladder sphincter function. But typically, if we get called to a medical or trauma emergency in someone who has a history of spina bifida occulta, that is not going to impact our care. And then spina bifida cystica includes meningocele and meningomyelocele. So meningocele contains portions of the membranes and cerebral spinal fluid, and the size varies. It can be really small through very large. There's no weakness of the legs or sphincter involvement, and then surgical correction is usually performed with excellent results. A meningomyelocele occurs when, in addition to the meninges, that membrane that you can see there that's red and very, well, it's clear, but you can see the blood underneath, and it's holding the CSF in. The meningomyelocele also includes the spinal cord. So the cauda equina, portions of the spinal cord protrude through that opening in the lumbar or sacral region. And this then oftentimes has associated paralysis of the lower extremities, poor or no control of bladder or bowel, and hydrocephalus is a common complication of the meningomyelocele. This requires surgery to close. And you might be saying, like, wow, I hope I never see this. But again, if you have somebody who is delivering prematurely, didn't receive regular prenatal care, that doesn't know that they have a child that has a neural tube defect, there is a chance that we'll see this in the field. So what I want you to take away from this is that it is really important that we don't break that sac. Upon delivery in the hospital, the newborn would be placed in an incubator. We don't have that option in the ambulance, so crank the heat and prevent heat loss. The baby should be placed prone with the head turned to the side. So this is going to be one of those times where we're actually probably not going to put the baby on mom, or if we do, they're both going to need to be fairly flat, and mom's not going to be able to put her arms, or I should say the postpartum patient isn't going to be able to put their arms around the baby, because we don't want any pressure or manipulation of that sac. You can use a moist, sterile saline dressing to prevent drying of the sac. You don't need to put any tape or anything. You could just kind of lay it over the baby. And then you could put like a Chuck's pad or something underneath the pelvic portion of the baby in case it urinates or passes stool. So our goal really is to protect that sac, that cyst, from injury, and to maintain a sterile environment as much as possible until they can surgically correct it. So you can see here with the meningomyelocele, the meninges is the outer part of the sac, the CSF is that darker fluid, and then the cauda equina of the spinal cord is looped out through that opening. This, again, you recognize that you have a problem. You respond by putting the baby prone and avoiding any pressure to the area, and then you're going to report it immediately. So this would, again, a surgical emergency, so we want to make sure that we call basically an OB alert on this, right? We want the pediatrician and we want everybody else there at the hospital when we arrive to take care of this baby. Ideally, they'd bring an incubator down, so like one of the warming sets down to the ER to put the baby in immediately upon arrival. Moving on from neural tube defects, another common injury that we see in children, or another common neurological complaint, is head injuries. This is a major cause of death in children older than 1 year of age. And there are obviously varying degrees of head injuries. Concussions have obviously been in the news and people are super concerned about them, but anybody who's participating in sports or any sport activity and sustains a head injury should be evaluated to make sure that there's no concerning findings for intracranial hemorrhage or bleeding, and to provide education and teaching to the family about what to monitor for and when to take the child to the ER. So a concussion itself is just a temporary disturbance of the brain that usually is followed by a period of unconsciousness. It's common for the child to report headache, fatigue, sensitivity to light or sounds, and even nausea. A single episode of vomiting is not concerning, but any child who vomits 3 or more times meets the criteria for a CAT scan. In general, short-term memory loss or some amnesia surrounding the events is not uncommon, but any of that fogginess or lack of recall should start to resolve within about 20 minutes. There should be some improvement, and if not, then again, you should seek medical care. Any child who isn't speaking correctly, walking into walls, can't move one part of their body, or has an abnormal neurological exam should also seek medical care. A child's response to a head injury may differ from that of an adult, especially if you have regression due to fear, anxiety, or pain. If they have an intracranial bleed or hemorrhage, a contusion is like a bruise basically of the cerebral tissue, and then bleeding into the brain can cause increased intracranial pressure. The trauma can cause cerebral edema, and if they have a skull fracture, they also are at risk for infection. We know that anytime there's swelling or bleeding within the brain, remember the Monroe-Kelly doctrine, there's only room for blood, fluid, and tissue, and if I increase the volume of any of those due to trauma or inflammation or infection, then I have to lose something else. So the balance is there, and I can't just willy-nilly increase one of those three components without losing something else. So what happens when I have swelling is that I basically push down on the blood vessels. I increase that cerebral perfusion pressure to the extent where blood pressure, normally is no longer able to perfuse the brain, and that results then in hypoxia. So when the brain senses that it's hypoxic, it starts sending out these chemical messengers to increase cerebral blood flow, and then that increases our blood pressure. So when we think about Cushing's triad and we think about hypertension, especially with a widening pulse pressure, so systolic hypertension along with bradycardia and irregular respirations, we're talking about a pretty significant head injury and a pretty significant increase in intracranial pressure. So the take-home is recognize abnormal neurological findings after a head injury early, and I think it's helpful to know the Canadian C-spine rules for neck injuries and the CAT scan rules for head injuries, to just think about which patients do or do not meet the criteria for a CAT scan, and which would be safe to release in the field versus which absolutely need to go to the ER. So signs of increased intracranial pressure could vary by age, but in the infant, it's going to be most unlike the adult. So we'll compare kind of the infant to the adult, and the child is going to be more like the adult. So first we see that they have irritability, confusion, lethargy, changes in mental status, or loss of consciousness. In an infant under a year of age, they'll also have a bulging fontanelle, and you may see, some changes around the orbits. If they could tell you, they would have blurred vision. You may get asymmetrical pupil responses, and then a really high-pitched cry and vomiting. Children who have head pain cry when they're moved or rocked, so normally that's consoling, and so that's really concerning. A child who can't be consoled, again, if the parent reports they're fussier than normal, it's very concerning to us. Blood pressure will increase, heart rate will decrease, respirations will decrease and become irregular, and then you may see posturing and or seizures. So again, any of those findings would tell us that this child has a significant head injury and needs to go to the hospital for a CAT scan. This is a picture of flexor and extensor posturing. Flexor posturing, also referred to as decorticate posturing, and then extensor posturing, also referred to as decerebrate posturing. And you may see this bilaterally or unilaterally in response to some sort of painful or noxious stimuli. It's really important that you document that appropriately. We know that survival rates are greatly decreased when we see posturing secondary to increased intracranial pressure. When you are caring for the child with a brain injury, you want to observe them carefully for signs of increased intracranial pressure. This includes mental status, so AVPU, and then a GCS, tool appropriate for their age. Pupillary reflexes, constriction, eye movement, vital signs, and looking for motor activity. There can be very subtle early clues of head injury, so it's important that you do a really organized and thorough physical exam. And remember that especially infants have an impaired ability to communicate and cooperate, and so you need to really understand normal growth and development in order to evaluate that patient. Cerebral palsy is caused by some sort of either birth injury, congenital anomaly, anoxic brain event, subdural hemorrhage, or infection that causes dysfunction of the motor centers in the brain. And this can be during pregnancy, during birth, or afterwards. The manifestations vary with each child. They can range from very mild to severe. And because this impacts motor centers, it does not necessarily cause a change in cognition. So they may be, cognitively intact, very bright and able to communicate and learn, but cognitive impairment can sometimes be seen if that part of the brain was damaged with the event. During infancy, if we see feeding problems or seizures not associated with fevers, a child who isn't meeting milestones, like rolling over or sitting up or reaching for objects by a certain age, we would start to suspect cerebral palsy. And since feeding problems are one of the biggest things that we see with this, it can lead to nutritional deficiencies. So the big take home with this is if you have a child that you respond to for, again, whatever medical or trauma reason, and they have a history of cerebral palsy, you want to know which kind they have. So spastic causes spasmodic movements. Athetoid causes these continuous involuntary movements, very similar to like Huntington's chorea. And ataxic causes uncoordinated movements and difficulty walking or inability to walk. So that would help you understand, what the baseline is for the child, but you also want to know whether or not they do have any cognitive impairments, because otherwise, regardless of how they communicate with you, you want to be sure to communicate with them appropriately for their age and cognition. So overall, it's just really important that we use age-appropriate knowledge, vital sign knowledge, and GCS knowledge to assess these patients. You want to check their response to pain, their arousal awareness, cranial nerve assessments, monitor their responses to treatment and interventions, and be alert for posturing. You always want to check pupils, the fontanelles, scalp veins, any changes in movement like ataxia or spasticity, and then any sort of changes in their reflexes like their Moro reflex or tonic neck reflexes. So thinking about kind of normal development in kids is really important when you're during your neuro exam. You know, I always say you can't recognize abnormal unless you know what normal is. So having some sort of cheat sheet or peripheral brain is helpful if, you know, you're not interacting with children frequently. As always, thank you for watching, and I will see you at the next one.